Sir, we are live now. You can start, please.
Yes. Good evening to all. This is Chandra Mohan, Ortho and Sports Physiotherapist from Dindivanam Sri Samraj Physiotherapy Center. A warm welcome to all the participants from our nation and abroad, and also from Fitness and Rehab India YouTube viewers for the ExRx India and Sri Samraj Health Service Private Limited, an attempt to a world record event, Webinar Super League, Session 30, Episode 63, in association with Pickle Studio, Sairam Academy, Dusa Creations, and Physioactive, powered by Fitness and Rehab India YouTube channel. Today's topic is biomechanics of the knee. We are happy and proud to have today's resource person, Dr. ANAND BABU, again in our webinar series. He is a biomechanic physiotherapist and he is working as an associate professor in Sri Venkateshwaraa College of Physiotherapy, Puducherry. I thank Mohan Krishnan sir for guiding me to approach him. I thank today volunteer Aziz from Chennai, and I welcome ExRx team, Dr. Rupesh and Professor Duna Saha. Now I welcome and request Dr. Anand Babu to start the session.
Good evening all, and welcome back for the session. Who are all attended already the shoulder complex with me. So we don't have much time to cover up all the knee complex, so directly go into the topic. I hope you got the screen, right? The PPT.
Yes, sir, it is visible.
Yes,
Please go full screen.
Fine.
Yes, sir. It's okay.
So today we
Hello, sir.
are going to see about the knee, learn about biomechanical thing, which if you want to know the entire biomechanics, it is not possible to convey everything within an hour. Even a single topic from the biomechanics of knee is very hard to describe within an hour. Like if you take ACL, it will take a long 4 hours to completely cover at least the biomechanic without a pathomechanics. So I just tried hard to make the PPTs which will be understandable and which comprise all the components of knee and their basic biomechanics. So I called it a basic biomechanics of knee joint, not a complete biomechanics of knee joint. So for your understanding, and who are all already finished up your studies, it will be a good revision for you. So coming into the introduction, so the largest and a complex joint in your body is a knee joint, because it is very, very complex, covered by 3 bones and a joint with n number of ligaments. Still the search of ligaments is still in progress. So many ligaments are in search, not yet find out the path of the ligament, the band of the ligament are still in a research process. So it is very, very complex to study compared to the other joint in our body. And for the functionally, it can be compared with the elbow, that it is actually do the function of closing and opening of hand to do the wide variety of functional activities. Knee joint is, unless your elbow knee joint is very, very important in both open kinematic and closed kinematic, train that during your walking, for the squat, and during to move the knee joint, progress your body through the space. It is very, very important. The equal importance of mobility and stability provided by the knee joint. You can say all the upper limb joints, it serves mobility than the stability, but the lower limb, especially your knee joint, serves equally the mobility function and the stability function, which is like for a walking, for a mobility, for squatting, for whatever functional activity, knee joint is very, very important. Consider if you tied the knee joint stiffer, and if you do the activity like squatting or walking, it is very, very impossible. So mobility is very, very important, and also bearing the body weight, your upper arm, trunk, and if you stand in a single limb, your opposite leg, everything is the weight of all the body bared by the knee joint and dissipated into the tibia, to the leg and to the ground. So the stability function is very, very important. If there is a loss of your stability component, like your ligaments or muscle, will have a great impact on walking. You can't able to walk properly. The knee will give way. You will tend to fall easily is avoidability. So it is equally important, mobility and stability for the function for the knee joint. The support of the body during the dynamic and the static activity, and it is as complex as it is prone for getting injury. So it's more complex, so it easily get injured. A lot of fine particles are present. The ligamentous connection, capsules, meniscus are very sensitive. Every part of the knee joint structures are weight-bearing structures, which provide stability, so it will be easily get injured. Broadly, your knee complex is divided into two joints, that is your tibiofemoral joint and patellofemoral joint. So patella articular with the femur is the patellofemoral joint, and the important what we colloquially call knee joint is tibiofemoral joint. In anatomy, we use total knee joint. It is simply a tibiofemoral joint. In this, we are going to cover the structure and the function of tibiofemoral joint. Structure, articular surface, and the weight-bearing structures, how your weight is distributed to the knee, and what are the structures which bear the weight, and the capsule, which is very, very twisty compared to the other joint capsule, and the ligaments. We are going to see the basic and important functional ligaments here, but we have a lot of ligaments than this. And also the bursa, which is smooth and the function of your knee movement. And the function, usually we see the biomechanics. We get into the osteokinematic and arthrokinematic motions and the muscle responsible for that motion. And finally, I already told you, because of lower limb, we have to say about stabilization. Without stabilization, the biomechanic will not complete, for especially lower limb. The structure of tibiofemoral joint, it's a double condylite joint, 2-degree freedom of motion, and some others says it's a 3-degree freedom of motion. That is some valgus and varus, normal valgus and varus movement, that is abduction and adduction is also possible in the knee joint. So it's a 3-degree freedom of motion now. Flexion extension and sagittal plane coronal axis, medial lateral rotation and transverse plane on vertical axis. That's vertical axis, sorry. Femoral articular, the proximal articular surface is a large medial and lateral condyle of the femur. These two condyles are separated by, you can see in the picture, it's separated by the intercondylar notch. Anteriorly, it is somewhat shallow, the saddle shaped groove that is to make the patella dislodge into it, that is called patellar groove. And the medial femoral condyle is larger than the lateral femoral condyle, and also the medial femoral condyle descends downwards than the lateral femoral condyle. Just keep it in your mind about that, because it's functionally very, very important that your locking mechanism and unlocking mechanism is going to happen because of this, that the medial condyle is larger than the lateral condyle. So concave, when compared to the femoral condyle, the tibial condyle is comparatively small. So definitely congruence with articular surface. The medial condyle is 50% larger than the lateral condyle and 3 times thicker. So the medial condyle bears a lot of force. That is why it's thicker and larger. Can you hear me? My internet is not stable. Is it interrupted? Can you hear me?
Sir,
Voice is little bit breaking.
Voice
but
is a
fine.
little bit breaking here, sir.
But other than that, it's
But
not
at least
disconnected,
understandable.
right? Fine, thank you. So it is separated by these two condyles separated by the intercondylar tubercle, and it is large intercondylar notch of a femur during the extension. So it's a tubercle which is dislodge the intercondylar notch of your femur during your flexion and extension. And the articulation, will we talk about the articulation? I already told you it is very, very incongruent, because the large femoral head have to articulate with these comparatively small tibial condyle. So there will be definitely is needed to increase the congruence, and thus the meniscal will do the job. In shoulder, we already know about the glenoid labrum. So here comes, it's a meniscus, which is functionally more important than your glenoid labrum. Meniscus, a two asymmetrical fibrocartilaginous structure, joint structure, meniscus, which is located on the tibial condyle, both the medial and lateral. Both are very, very thick in periphery to make, to confirm the head of the femoral condyle not to displace from the tibial condyle. So the periphery is thick, like we can imagine like a lake which is covered by the circumference, a thick height circumference. Okay, so which look like that. That will get the femoral condyle into it, and it allows it will not let the femoral condyle move outward during the movement. The main function is to reduce the friction, weight distribution, and act as a shock absorber. The attachment of the meniscus, we have medial meniscus and lateral meniscus, both are connected around. Actually, I already told you it is not enough to describe the mechanism of meniscus within an hour is very difficult task. So I just going to convey what are the connection it have with the other component of the knee joint, so that you may know, you may aware of how important the meniscus is, and each and every connection have an importance in functionally. Both the meniscus connected to the periphery of the tibial condyle by the coronary ligament. So it will be given attachment to the tibial condyle, peripheral tibial condyle by the coronary ligament, and both attached directly or indirectly to the patella by the patellofemoral ligament. So it serves integrity for your patella to the tibia also. Keep in mind. And end of the meniscus is attached to the respective tibial intercondylar tubercle, that is called horns. So anterior it is called anterior horns, and posterior it is called posterior horns of two cells. So medial meniscus have anterior horn, posterior horn, lateral meniscus have anterior horn and posterior horn. The anterior horn join together at the anteriorly to form the transverse ligament. So each two meniscus is separated, and two meniscus is attached to each other by the ligament called transverse ligament. And the posterior horn, the lateral meniscus have greater zone. The surface area of the lateral meniscus is larger than the medial meniscus. In compared to the anterior horn area, the lateral meniscus is somewhat thicker than the medial meniscus. It's functionally important. And the lateral meniscus attached for a number of attachments coming from the meniscus to all over the knee, which is your anterior lateral meniscus attached to the posterior cruciate ligament, popliteal muscles via coronary ligament and posterior capsule. Some fibers also have contributed to the ACL, which directly attached to the anterior and posterior horn cell of lateral meniscus, and the lateral meniscus attached to the medial collateral ligament. The medial meniscus attached to the medial collateral ligament, semimembranous via capsule. So through the capsule, it attached to the other ligaments, it attached to the muscles which connected to the knee joint. So it is integrated, or it is supported fully by all the surrounding passive and active structure. Whenever I mention the passive structure and active structure, the passive structure only indicate the capsule and ligament. Okay, so that is the passive structure of knee joint. So which create a passive tension during the movement of your knee complex. And your active structure of knee complex is your muscles, aponeurosis, and tendon. So the tension in the tendon is a tension created by the muscle, by the tendon, by the aponeurosis connection of the tendon is your active tension. So keep it in your mind. So passive tension is your capsule and ligament, active tension is your muscle and associated tension. 4. The medial meniscus is somewhat firm and less mobile than lateral meniscus is also very important. So because of this, the pathomechanics, the medial meniscus is more prone for getting tear than the lateral meniscus, because lateral meniscus is somewhat movable, so it will adjust according to the movement of the femoral condyle, but medial meniscus can't able to move according to the movement, so it is very firm. Whenever the twist happen to the tibia, or whenever the twist happen on the femur when the tibia is on the ground, definitely first your medial meniscus gets affected because it is firmly attached. It is not having a mobility like your lateral meniscus. So horns are very weakly innervated by free nerve endings, Ruffini, Pacini, Golgi tendon organ. These are all the nerve endings which sends the information about the positioning, movement, weight bearing, and everything to the central nervous system. So this is about the meniscus. Now, the tibiofemoral alignment and weight bearing force. So tibiofemoral, how the tibia and femur is aligned. So the angle which is normally formed by the femur and the tibia. So the femur is a axis. The femur axis is somewhat obliquely directed, that is inferiorly and medially, which is not straight. Whenever we keep the femur will somewhat directed inferiorly and medially, and the tibia we've seen at most vertically. So definitely these two bones will form on a medial oriented angle about 185 to 90 degree medially. Okay, so the measurement is medially, so that I marked here in the picture that the medial thing. If you marked it laterally, then it comes around 175. Forget about it. Just think the angle formed medially. So the medial angle formed is 185 degree to 190 degree is normal. So that created a physiological valgus at the knee always. And it seems, okay, so whenever we see that the physiological valgus occurs, so most of the weights go to the lateral condyle, but it is not true. Okay, even though it have a physiological valgus, the weight distributed from the femoral condyle to the tibial condyle is equal. From the medial condyle and the lateral condyle, the weight distribution is equal. And the line process through the center of the, how to assess it is the line process through the center of the knee joint between the intercondylar tubercle is an angle formed by the tibiofemoral. We call it as tibiofemoral angle. Okay, it's somewhat related to the Q angle, which I tell later about the patella. So patella is purely because of the quadriceps pull, that is Q angle. It's different from the tibiofemoral angle. If you mention about the tibiofemoral angle, 185 degree. If you mention about quadriceps angle, it's what different. I will tell you later. It's just 15 degree. It's normally. Okay, so the weight bearing stress on the knee between the strands equally distributed to the medial and lateral condyle. Whenever we stand straight and equally we distributed our body weight into two, to the right leg and leg. If you are 100 kg weight, both the leg will bear 50 kg, 50 kg. In which from the 50 kg transferred from the femur to the tibia, medial condyle of tibia receive 25 kg and lateral condyle of tibia receive 20 kg, irrespective of your angulation formed between the tibia and femur. So the deviation of the force will distribute meniscus. If the force is concentrated on more on any other condyle, then it is a deformity. So if the medial tibial femoral is greater than 195, then it is called as genuvalgum. You can see in the picture, the third picture. If it is increased, that increase the lateral compressive force of the knee joint, and the force will bear more laterally, and that creates tension, compressive force to the lateral compartment and tensile force to the medial compartment. Again, it creates a continuous tension on both the medial and lateral compartment, passive structure and active structure, passive force and active force, and create a deformity. If it's less than 180 degree, then it is called as genuvarum, which increase the medial compression force and lateral tensile force. Okay, so this is the main weight bearing in a normal standing or non-weight bearing, whatever. Static weight bearing. Dynamic weight bearing, how the knee joint bear the dynamic weight bearing, like walking, stair climbing, running, or squatting. So usually during your walking, during your stair climbing, your knee joint receives 2 to 3 times more than your body weight. If you are about 100 kg, while you are in a dynamic phase, your ground reaction force act on the body, and the body pulls downwards to the knee joint, and the ground will try to push out our body. So it tend to 2 to 3 times more the body weight. If you are 100 kg of weight, your knee is supposed to get nearly 200 to 300 kg of weight while you going for a stair, while you walk for a long or running. Yeah, and in which your meniscus will impose most of the weight. Okay, so all the weight will actually it's imposed to the meniscus. 40 to 60% of weight imposed to the meniscus. That is why meniscus get easily damaged. And the squatting is very, very crucial role for your knee joint. So once you get into the squat, you will may receive nearly 5 to 6 times of your body weight to the knee joint. So that is why during osteoarthritis or any other knee problem, we ask the patient to avoid squatting system. Move on to the knee joint capsule. So knee joint capsule is a large capsule, completely covered the knee, and posteriorly it attached to the posterior margin of the femoral condyle, intercondylar notch, and distally to the posterior tibial condyle. It's covered like a package. Okay, it's just an attachment for the namesake, but it's from the upper part of the femoral condyle to near the fibula. It will attach completely like a package. So anteriorly, it will attach to the patella. It covers the patella, and superiorly it inserted or it will arises from the quadriceps tendon, inferiorly up to the patellar ligament, and anteromedial and lateral. Anteromedial, it will cover up to the attachment of, it will reinforced by the vastus medialis. Anterolaterally, it will reinforced by the vastus lateralis muscle. And anteromedial and the anterolateral portion of the capsule is called extensor. The thick portion which is covered the knee joint. The thick portion of capsule covered the knee joint anteromedially and that extensor are medial lateral patellar retinaculum, and it's functionally important. And the synovial ligament or synovial covering of capsule. So the synovium which adheres the inner wall of the capsule, you know that in a synovial joint, all the synovial lining which adheres with the capsule. And here the synovium is not much adhered at the posteriorly. The synovial lining have a infolding at the ACL and PCL. You know, the ACL and PCL run inside the joint. The ACL, I will tell you the attachment later. ACL and PCL which runs into the joint and synovial fluid. So it is the synovial lining covers the ACL and PCL, which the synovial fluid will not enter into the ACL and PCL. The synovial lining of capsule is divided into 3 compartments or septum during your life embryo. The superior, medial, and lateral patellofemoral compartment, and superior compartment recesses into the suprapatellar bursa after the 12 week of after you born. The child, all the synovial lining, that septum will merge into a single packet of capsule, or it's somewhat converted into the bursa. If it persists, if the septum is persist in adulthood as a fold of capsule, then it is called as LICA. So if the LICA will get inflamed, then it is called LICA syndrome. We can assess the LICA syndrome through MRI, whether the LICA exists, and if there is an LICA again due to the bone flexion and extension, it will compress against the patella and the femoral condyle and leads to the inflammation. It's mimic of your inflammation of patellofemoral joint, like the swelling, redness, and everything will be present, and the joint effusion will be present. But while we assess, we can get to know that this is LICA syndrome. Move on to the knee joint ligament. Knee joint ligament, the main ligament which we are going to see now is, I already told you, it's have a lot of ligaments. The primary important which produce the anterior stability, posterior stability, medial stability, lateral stability. That is what we are going to see. That is your collateral ligaments that provide medial lateral stability. Cruciate ligament, we have anterior cruciate and posterior cruciate provide anterior and posterior stability. And posterior capsular ligament. Why posterior capsular ligaments? It consists of a number of ligaments which supports posteriorly. Anteriorly we have patella, and the quadriceps tendon and the patellar ligament covers the anterior part of the knee, which supports the anterior cruciate ligament from prevent the instability. But posterior we have only posterior cruciate ligament. So some other important ligament structures covers the posterior part of the knee joint, which also helps to prevent the posterior excursion of your femoral condyle from the tibial condyle during the movement. And iliotibial band. So you know the iliotibial band is part of a muscle. Why it comes under the ligament? I will let you know later. Collateral ligaments. We have medial collateral ligament, lateral collateral ligament. Medial collateral ligament attached to the medial femoral condyle, slopes anteriorly and inserted into the medial aspect of your proximal tibia. So what is the function of medial collateral ligament? It resists the valgus stress effectively when the knee is in full extension on slight flexion. And check the lateral rotation of the tibia throughout the range. From the extension, mild flexion to complete flexion, it checks the lateral rotation. And if the ACL is absent in some other condition, or ACL is completely torn, then your MCL will come into act to replace the ACL, that it prevent the anterior displacement also. If ACL is intact, it will do the work of prevention of anterior displacement of your tibial condyle from the femur. But if it is absent, your medial collateral ligament somehow help to do the action. Lateral collateral ligament, the strong cord-like structure, that is a lateral collateral ligament, you can see in the picture. From the lateral femoral epicondyle to the posterior head of fibula. And it resists the varus stress, that is your abduction stress. adduction stress, and it limits the lateral rotation of the tibia at 35 degree of knee flexion. Actually, it will prevent the lateral rotation at the whole movement of your knee complex, but especially 35 degree, it will become so taut. And also it resists the posterolateral displacement along with the muscle popliteus. So this is the basic thing of collateral ligament function, but the collateral ligament the function is not ended here. It have a lot of function, so it will come in a separate entity. It's not possible to cover all those things. So the basic biomechanics and basic function of collaterals I just mentioned here. And again, the very crucial ligament of knee joint, which is very, very prone to injured, especially in a sports community, the cruciate ligament. We have anterior cruciate ligament and posterior cruciate ligament, which lies centrally within the capsule and outside the synovial cavity. That's what I said. Okay, so it encloses inside the capsule, but the synovial lining covers both the cruciate ligament, which makes it separates from the synovial cavity and synovial fluid inside. And it is made up of main cell is fibroblast. The type 1 and type 2 collagen is abundant, which means it makes it will absorb more and more tensile force and it will more compressive force. So type 1 collagen and type 2 collagen is meant for this type of collagen. Actually, we have a lot of collagen, more than 15 types of collagen is here. Each and every collagen present in the ligaments, capsule and the tendon, which have each and every collagen have a unique work in which type 1 collagen and type 2 collagen have bearing the tensile force. It is very tough type of collagen which bear the tensile force and compressive force more than any other structure. Move on to the anterior cruciate ligament. From the anterior tibia, it passes under the transverse ligament. So you can get the where is the transverse ligament, the anterior uniter of anterior horns of both medial and lateral meniscus. Okay, so the ligament which unites the anterior horns, it will pass under that ligament. So it will pass under the transverse ligament and extend superiorly and posteriorly to the part of inner aspect of lateral femoral condyle, arise from the tibia, end at the femoral condyle superiorly. So it has two bands, very, very important, anteromedial band and posterolateral band. So each and every band have a different function. I just mentioned some of the important function of the band. The primary function of the ACL is to restrain of anterior displacement of whether tibia while it moves against the femur, or it will prevent the movement of femur against the tibia, whatever, in the closed kinematic chain and open kinematic chain. So 87% of its function covers the anterior, restrain the anterior displacement, in which the posterolateral band of your ACL injured in hyperextension, whereas anteromedial band will injured during the flexed knee. Okay, whenever your ACLs get injured, if it is a flexion type of injury, you can directly guess that the tear is at anteromedial part. If the injured caused due to any hyperextension in the sense while doing kicking a ball in a football, while try to kick the ball, or someone will tend to push your knee from posteriorly, it will get your ACL will get injured. So mostly the type of injury will caused by the type of injury will tear the posterior lateral band of your ACL. When MCL injured, the medial collateral ligament injured, ACL will also restrain the since it supports the valgus and varus stress. It will accept the varus and valgus stress. If the ACL get torn, there will be both anterior medial and anterior lateral stability will occur. Okay, so ACL will not only provide the anterior stability, it will also provide anteromedial and anterolateral stability. Once it get affected, definitely your knee will in a local language will tell the knee giving way movement will occur. So whenever you attempt to walking, you just feel like your tibia move forward than the expected level. So you have a fear of that your knee is going to come out, your tibia is going to come out from the femur, and your hamstring muscle, which pulls the tibia posteriorly, have act as a synergist for your ACL. Posterior cruciate ligament, again it's made up of basic cell structure chondrocyte, and type 2 collagen is more, so it is more tensile stress. It have more tensile stress than the compressive stress. It arises from the posterior tibia and runs superiorly and anteriorly inserted into the anterior aspect of femoral condyle. And again, it arises from the tibia and goes superiorly attached to the femur. It is very short and less oblique than your ACL. Unlike your ACL, which have the two definite band, that is anteromedial band and posterolateral band, your PCL not have definite bands. It have a multiple fibers, so each and everything we can able to split it up, each and every band separately, but the group of some splitted band we can call it as anteromedial band and anteroposterior band. So anteromedial band lacks in extension, which is loose in extension, and posteromedial band will get so tight during your 80 to 90 degree of flexion, and anteromedial band will be tight whenever the posteromedial band will get lax. Okay, so it is a unique function that whenever the anteromedial band get lax in the sense it will get loose, then your posteromedial band will come into the action, that it will get tight and it will prevent the knee joint to going posteriorly. And anteriorly, I already told you it have a special structure. We have patellar tendon directly attached to the patella, and it continues as a patellar ligament inserted to the tibia. So the anteriorly it is somewhat safer for the displacement of the tibia when compared to posteriorly. So we need some of the structures, important structure, which covers the posterior part of the joint also. The primary function of your posterior PCL is restrain the posterior displacement of the tibia. So mostly during the 93% of posterior load is carried by the posterior cruciate ligament. Maximum posterior displacement occurs during your 75 to 90 degree of flexion. And again, like your ACL, PCL also have restraint force of valgus and varus, and it is also active during the rotations of tibia, medial rotation, lateral rotation, in both the rotation. In extension, your posterior cruciate ligament taut and create a lateral rotation of the knee to a critical locking mechanism. Okay. In your anatomy, you may study like locking mechanism and unlocking by the popliteal muscle or something. Okay, so biomechanically, popliteal muscle is just an accessory muscle to provide unlocking mechanism, but locking and unlocking is purely a passive movement. Okay, passive movement, not by the any active movement, that is muscular movement. It is passively done by the capsules and the surrounded ligament and the contour of your bone. That is what I just remind you at the articular surface, that it is important to know whether the lateral condyle of the femur is small compared to the medial condyle is helpful for locking and unlocking mechanism. And you are during a complete extension, your PCL pull the medial condyle of femur to make it lock. And again, popliteus is adjunct for your PCL as active component. And I already told you some of the ligaments which support posteriorly to maintain the integrity of your femur and the tibia. That is oblique popliteal ligament, cruciate popliteal ligament, popliteal fibular ligament, and meniscofemoral ligament. So the I already told you about the meniscofemoral ligament. Some of the fibers which arises from the posterior meniscus and it directly attached to the femur. So that is meniscofemoral ligament. These are all the structures which supports the joint posteriorly along with your PCL. So these are about the ligaments. We have a lot of ligaments more than this. For the further class, I'm going to mention a lot of ligaments which supports the patella, which supports the tibia to the femur and femur to the tibia, which I didn't mention at the list of the ligaments because it is not much important, but I will tell the important function of that particular ligament at the time of function while studying about the weight bearing function of your patella, while I'm telling about the movement of your knee joint, arthrokinematic movement of the knee joint, what are the ligament structure which supports the movement of the femoral condyle on the tibial condyle, which is not mentioned at the topic of ligaments. Although it is a muscle, it is essential passive structure of the knee joint. It reinforces the anterolateral knee, and it always taught regardless of your hip joint or knee joint position. So iliotibial band draws posteriorly when the knee is flexed beyond 30 degree, and it also works as a posterior stability. It's anterolateral knee stability, provides the anterolateral knee stability while in extension. While if you go beyond the 30-degree flexion, it will drop posteriorly and supports the knee joint posteriorly. So it is very, very important to restrain the anteromedial and posterior part of the knee joint. So, and iliotibial band is a part of passive structure. That is why I mentioned it in a kind of a ligament, not on the muscle. The knee joint bursa, you know the function of bursa. So it reduces the friction between the intertissue structures during the movement. So without bursa, directly two structure which directly come into the contact during the movement, and the more friction will occur, that will lead to inflammation, rupture, micro trauma, and everything. So the main function of your bursa is to avoid that friction. That is will prevent the degeneration. So that is what the thing to bursa. In knee joint, we have a lot of bursa. Importantly, your suprapatellar bursa, infrapatellar bursa. I didn't mention here. It's just below the patella. Infrapatellar bursa, suprapatellar bursa, which just lies above and below the patella and smoothen the function of your quadriceps muscle during flexion and extension. And subpopliteal bursa, which present between your posterior tibia to the popliteus muscle, and which smoothen the movement of joint while popliteus muscle come into action. And again, under the gastrocnemius, we have a gastrocnemius bursa. So these are all the important bursa: suprapatellar, infrapatellar bursa, and subpopliteal bursa and gastrocnemius bursa. Now, this is the structure we completed of the knee joint, that is tibiofemoral joint, and the function of knee joint. So we separated the function into osteokinematic and arthrokinematic. In arthrokinematics, we exclusively going to see about the locking and locking mechanism and axial rotation. Osteokinematics, primary angular or rotatory movement of the tibiofibular joint is flexion extension. Flexion extension is more predominant in your knee joint. In anatomy, it is believed that it is a hinge joint producing only flexion and extension. I just forgot to tell you about that. So for the students who just cross your anatomy, you may thought that the knee joint will do flexion and extension, right? So the predominant of movement is flexion and extension, but it is also do the medial and lateral rotation, and also varus and valgus movement, that is abduction and adduction. I'm sorry, the spelling mistake, it's both adduction, but it's abduction and adduction motion. Also occurs some lesser extent, so it is ignorable. It's just during the weight bearing structure, the minimal, or during the open kinematic exercise voluntarily. If you do passive movement of valgus and varus, you can see a mild abduction or adduction of the movement. Okay, so widely flexion and extension and some sort of medial rotation and lateral rotation is important for the function, and very, very minimal valgus varus movement, that is abduction and adduction movement. The small amount of anterior, posterior, and the medial lateral displacement is also occurred. Actually, still the investigations going on that it is not 3-degree freedom of motion; it's a 5-degree freedom of motion, which also have the displacement of anterior, posterior, and medial lateral. But it purely caused because of the ligamentous laxity, the elasticity of the ligaments. It's somewhat your knee will go forward or backward or just medial and lateral without doing abduction. It just go in a horizontal plane movement. So that may occur in also. So what actually the position affects the motion of the knee joint, whether if the hip is whether the hip, I'm getting something interrupted. Can you hear me right? Actually, if you can't able to hear properly, just inform me. I'm just running into the flow.
Sir, a little disturbance was there a little earlier, but now it's all right.
Okay, ma'am. Thank you.
Yes.
About flexion extension, osteokinematics, it's purely about the range of motion. The axis for flexion extension of your tibiofemoral joint lies horizontally between the tibia and femur through the femoral condyle. It passes through the femoral condyle, and it is somewhat oblique axis. If you aware about the elbow joint axis, it's somewhat oblique while you do the flexion, your radius and ulna will not directly come onto the shaft of the humerus. It will somewhat goes medially because of the axis obliquely. Likewise, your knee joint is somewhat oblique. Whenever you attempt to do the movement, the tibia will not come directly behind the femur. It somewhat and again full extension. The because the axis is somewhat oblique. So the tibia moves slightly laterally during the full extension, and it comes medially during a full flexion. And if you go have fixed axis, that your olecranon process move inside the olecranon fossa as a fixed axis, but in knee joint it's not going to happen. So each and every point of your femoral condyle come into the contact with the tibial condyle at each and every range of motion. So that instantly changing the axis of motion or axis of rotation is called instant axis of rotation, IAR, that will present in a knee joint. So the pathway of instant axis of rotation is somewhat semicircular, which that is your femur will not completely roll on your tibia. It will roll. Along with that, it will move medially and laterally. Along with that, it will slide anteriorly to keep the congruence or to keep touch within the tibial condyle. So in a closed kinematic chain, it's supposed to sit or stand. If you do the movement of femur on the tibia, the femur have to move in a different axis, that is your instant axis of rotation. Usually it won't happen at your shoulder joint or elbow joint. So the many author says the knee joint muscles is many of the knee joint muscles are your two joint muscles. So definitely the position of hip joint will have an impact on the knee joint. The passive range of motion of the knee joint is 130 to 140 degree. It will limit 120 or less if the hip is hyperextension, that I mentioned in the second picture. And during the squat, it will go beyond 140 degree, that up to 150 degree. If you try to flex your hip and ankle, then it will go beyond the range. So the ankle joint is also very, very important. The position of the ankle is very, very important, which decide the range of motion of the knee, mainly during the closed kinematic exercises. For the normal gait, we require only 60 degree of flexion. For stair climbing, we need only 80 degree of knee flexion. And for sitting, we need 90 degree or more. It's depend upon the position of sitting. So coming back, ankle by any means, and if you trying to lift your leg, if you try to lift your knee, it is not possible for make the move without movement of your ankle. So whenever you try to attempt to lift your body, lift your knee joint during the closed kinematic chain without the movement of your ankle joint, it's not possible to make a move. So the ankle joint is also how coordinately with the kinematic of rotation. That's a medial and lateral rotation mentioned in the picture. There's a two type of rotation, differ structurally and functionally. So when we come into the rotation, we have two type of rotation. I already told you that's a normal axial rotation. That is what your medial rotation, lateral rotation, and your terminal or automatic rotation, which is not done by the muscular structure, which is automatically done when you attempt to do the full degree of extension. The final degree of extension is done. That is called locking and unlocking mechanism or terminal and automatic rotation. So two different types of rotation. We'll see automatic rotation that is providing the close pack position of the knee in detail at the orthokinematics, because it's purely done by the ligaments which lock the knee in a full extension. Coming to the axial rotation, so the longitudinal axis that run closely to the medial tibial intercondyle tubercle. So again, I'm mentioning the medial tibial intercondylar axis. So the lateral tibia is going to rotate around the medial tibial condyle. Okay, it occurs due to the articular incongruence and the ligament laxity. It's somewhat shifted on the medial side. Usually, if the equal range of rotation will occur if the axis passes in between the intercondylar tubercle, but it somewhat moves medially because of articular incongruence and the ligament laxity. When the knee is complete extension, there is no axial rotation possible. That is close back position for the knee joint. But at knee is 90-degree flexion, the more number of the lateral rotation, medial rotation is possible. Degree of rotation is possible. That is lateral rotation 40 degree and medial rotation 30 degree. Coming to the kinematics of flexion and extension. It's simple, like if you look at the glenohumeral joint, you may know how your head of the humerus moves on the small glenoid cavity. It's not only roll, along with the roll, it has to slide downwards, it has to flow medial and lateral. The same scenario occurs with the knee joint also. Flexion extension, so I'm mentioning knee joint. Knee joint is meant for patellofemoral. Sorry, knee joint is meant for your tibiofemoral. So knee joint and tibiofemoral is similar. Flexion extension, the large femoral condyle are relatively moves on a relatively small tibial condyle. So whenever we attempt to move the femur in a close kinematic chain, the femur tend to move on the tibia or move out of the tibia. So during flexion, the femur roll posteriorly. You know the arthrokinematics, concave convex rule. Whenever the concave structure is fixed and convex structures move, the rolling will be occurs in the opposite direction of the movement. So the femur will roll posteriorly. Femur will roll posteriorly. When the large femoral condyle roll out of the tibia during the before the full flexion occurs. So the femur have to glide somewhat anteriorly. So up to 25-degree of flexion, your femur will occur, only the pure rolling will occur up to 25-degree of flexion, and then it will accompany along with the anterior gliding. So from extension to the flexion, again the same scenario occurs from the extension to flexion. So extension to flexion, the femur will roll anteriorly and slide posteriorly. So this sliding movement of posterior glide and anterior glide is done by your ACL and PCL. So ACL guide the anterior gliding and PCL guide the posterior gliding. It's not only by the ACL and PCL. The important factor which provide the gliding, anterior gliding and posterior gliding is ACL, PCL, and some of other passive tension, other passive structures also come into guide to pull the femoral condyle anteriorly or posteriorly during the flexion and extension. And meniscus is also very have an important role. It's have a separate entity that it have direct connection to the femur, so it pulls the femur anteriorly during the flexion and it pulls the femur posteriorly through the ligament connection to the capsular connection. That's how it maintains the integrity of your femoral condyle with the tibial condyle during flexion and extension. And another thing is locking and unlocking mechanism. I already told you. So you have a medial condyle is somewhat larger, that already fixed. Medial condyle is somewhat larger than the lateral condyle, which I already saw at the articular surface. That is going to help in locking and unlocking. During the final 30-degree of extension from the flexion, the lateral femoral condyle will complete its rolling, gliding mechanism and everything. So it will roll, glide, and everything will be completed by the muscle. But the large femoral condyle will continue to rotate on the femur, hence it is larger than the lateral condyle. That final degree of medial, medial condyle rotation will help to do the locking mechanism. So the medial rotation of the medial condyle is more evident at the final 5-degree of extension. If any passive structure or passive force is absent, then you will evident of your extensor lag, that you can't able to keep the knee straight extension. You have somewhat 5 to 10-degree of lag will be evident because of absence of this locking mechanism. So the locking mechanism is purely done by the supporting passive structures, not by the active tension or active structure. The medial rotation of the femoral medial condyle of the femur occur without any muscular action. That is why I told you that it's purely by the passive ligamentous tightness. So it is called as automatic rotation or terminal rotation. That is why it is unique when compared to the other axial rotation. Okay. So it does not comes into the axial rotation, because axial rotation is done by the muscular structure, and locking mechanism or unlocking. Unlocking is also purely by the passive structure, not by the active structure. The popliteus muscle will help to unlock the knee joint, but even if the popliteus get paralyzed, or if you remove the popliteus muscle also, there you can see the unlocking mechanism. So popliteus is just adjunct for the unlocking mechanism. In anatomy, we may study the primary muscles of unlocking is popliteus, but mechanically now it is found that locking and unlocking both are passive mechanism, not by the muscle. But the muscle is working. Mostly it is done by the most of the locking and unlocking done by your passive structures. Axial rotation done by the muscles. The axis lies between that is what at the medial tibial intercondylar. So I told you the medial tibial intercondylar. So the medial condyle fixed and the lateral condyle have to move more, and hence the lateral condyle widely on the move on your medial condyle during the axial rotation. That is medial rotation, lateral rotation. During lateral rotation, tibia moves on the femurs. If it is in case of your open kinematic chain, the tibia medial condyle slightly moves anteriorly, while the lateral condyle have to move large distance. That is what I mentioned in the picture, that your medial condyle is somewhat larger, so it will just go forward and backward during the rotation. But your lateral condyle have to move, create an arc anteriorly and posteriorly to provide the medial and lateral rotation. So that is what occurs. If the lateral condyle moves anteriorly, then it is a medial rotation. If it is in a reverse direction, it is a lateral rotation of your tibia. And the things which doing the action, flexion, extension, medial rotation, lateral rotation, are varus and valgus, done by the muscles. So each of the muscles that flex, extension, the knee has broadly your knee joint. I already told you the predominant action of your knee joint is flexion and extension. So we categorize the muscle into flexor and extensor. Each of the muscles that flex, extends the knee has a momentum that capable generalize both frontal plane and transverse plane motion. So flexor, for example, hamstring muscle is not only do the flexion, it also do your medial rotation and lateral rotation along with the flexion. And extensor quadriceps, your vastus medialis and lateralis is there. So both will do lateral medial rotation and lateral rotation respectively along with the extension. So broadly your knee muscles are categorized into flexor, extensor. Flexor, we have 7 muscles which do the flexion of the knee joint, that are semimembranous, semitendinous, biceps femoris. So is a group of hamstring muscle, and sartorius, gracilis, popliteus, and gastrocnemius muscle. And 5 of the flexor, that is popliteus, gracilis, sartorius, semimembranous, and semitendinous muscle, have potential to do the medial rotation of the tibia on the fixed femur, whereas the biceps femoris has a momentum to capable of doing your lateral rotation. That is why I already told you that your flexor will also do the medial and lateral rotation. Likewise, the extensors are also capable of doing your rotation movement. So there is no exclusive muscle for medial rotation, lateral rotation in the knee joint. The lateral muscles, that is biceps femoris, lateral head of gastrocnemius, popliteus, are capable of producing your minimal valgus movement, whereas your medial side muscle, that is semimembranous, semitendinous, and the medial head of gastrocnemius, sartorius, gracilis, that's actually 3 of these muscles, semimembranous, semitendinous, gracilis, sartorius, will also provide the varus movement, that is your abduction movement. So now the hamstring muscle, mechanism of hamstring muscle, semimembranous, semitendinous, and the long and short head of biceps forms the hamstrings mainly. These muscles attach proximally with the ischial tuberosity of the pelvis, except the short head of biceps from the pelvis. Short head of the biceps arises from the femur itself, posterior part of the femur. Tendinous muscle attached distally to the anteromedial aspect of the tibia, where to the common tendon insertion, that is sartorius and gracilis muscle. So insertion of sartorius, insertion of gracilis.
Excuse me, sir.
Hello, sir. You there? Anand, sir, you there?
Sir is got stuck, ma'am.
Seems some network issue is there. Let's wait for some time.
I think so, but his name is shown. Slide is shown.
Some kind of
Hello?
audio failure is there, it seems. Yeah, he got disconnected. Sir, please try to contact him. Anand sir, you there? Please unmute your mic.
Yeah.
Yes.
Share your screen, sir.
Can you hear me now?
Hello,
Yes,
Anand
sir,
sir.
we can hear you.
Your audio
Yes.
is failure. You will be back. You will be.
Can you hear me right?
Yes,
Shall
sir,
I continue?
we can hear you. Please repeat the last few sentences you have made because
Okay,
we could
so
not hear you. Yeah.
okay, I'll start from the hamstring muscle again. So
Yes.
hamstring muscle is comprised of semi-tendinous, semi-membranous, and the long and short head of biceps femoris, which is collectively called as hamstrings. And these muscles are attached proximally from the ischial tuberosity of the pelvis, except the short head of biceps, which arises from the femur itself. The semi-tendinous muscle attached distally at the anteromedial aspect of the tibia with the common, it shares the common insertion with the sartorius and gracilis, and these common insertion point is the tendon, three tendon which insert at the common point is called pes anserinus. Pes anserinus we can call like we otherwise colloquially it called a guy rope tendon. Guy rope in the sense like a tin. So semi tendinosis arises from the ilium, and your gracilis arises from the ilium, and your sartorius arises from the ilium. So it arises three part of the pelvic bone and insert into the common point like the rope tied in a tent or a pole for a electric post or something. So it's functionally work like that. So it will stabilize the femur originated from a different part of the pelvis and insert so and serious tendon, this three tendinous insertion called semi-membranous muscle inserted posteriorly, semi-membranous insert posteriorly on the tibia, and both the head of biceps femoris is inserted at the head of the fibula. So this is a picture, and mechanically your greater hamstring force produce the hip of the joint regardless of knee position. So whatever the knee position is, whenever your hamstring muscle, is it audible, right?
Yes,
Hello?
sir.
Yes, sir, you are audible, sir.
Okay, ma'am. Actually, I'm getting the message that the connection is interrupted in between. I don't know. So
They
mechanically,
may be privately sent to you. Please continue, sir.
okay. The mechanism, a hamstring will produce a greater flexion force irrespective of any knee position. But whenever you try to do the hip extension along with the knee flexion, you will get the passive insufficiency. So for the newcomers or the students, I just want to tell you about the passive insufficiency. Whenever you try to attempt to do the action of a muscle, all the action of the muscle together, it can't be able to do its fullest energy or fullest form of movement. That is called passive insufficiency. For example, in your limb, all the muscles of your extensor expansion will crosses your wrist, your small joints of your hand, proximal intervention, distal intervention. So if you try to attempt the flexion of your when you try to attempt the flexion of your wrist joint, you can't be able to do the finger flexion along with the flexion of the wrist. But if you do the extension, you can able to do a good flexion. Okay, so that is the passive insufficiency. It's already do a stretch. Your extensor muscle is already stretched at the wrist. Then if you try to stretch it along, you can't be able to do that. That is what passive insufficiency. Whenever the two joint muscle, it definitely will go for passive insufficiency if you try to attempt to pull the muscle at all the joints wherever it crosses. So that is passive insufficiency. With the two joint hamstring, it's required to contract the hip extended and the knee flexed to 90 degree or more. Temporarily, the hamstring muscle go for shortening and it will create. And the biceps femoris muscle is also stabilize the posterior-medial aspect of the knee joint. So that is a primary importance of your hamstring muscle. Gastrocnemius muscle, the gastrocnemius muscle which arises at the two head arises from the posterior aspect of the medial and lateral contact of the femur and attached distally to the tendo-achilles, the posterior calcaneum along with the tendo-achilles. Gastrocnemius muscle is the only muscle which crosses both the knee joint and ankle joint. Other muscles are crosses the hip joint and knee joint. Only muscles which cross hip joint, knee joint and ankle joint is gastrocnemius muscle. Gastrocnemius muscle more relatively small contribution of knee flexion because it's great in your weight bearing and ankle joint movement. Very minimal action at the knee joint. Okay, so it's produce very minimal momentum. It creates very minimal momentum for knee flexion. And the knee flexion torque mainly produced during the full extension. When you start flexion, it loses the integrity between the tibia and femur, and it works more on the ankle joint. So whenever the knee continues flex, the ability of gastrocnemius muscle to produce knee flexion torque is significantly diminished. So full extension, your gastrocnemius will work. When you start to do the flexion, your gastrocnemius muscle will, the work will reduce. However, the gastrocnemius muscle is very important. It works synergetically along with the pull of your quadriceps during the functional activity like stair climbing or running. So it holds the knee joint that the anterior structure produce a tension by the quadriceps muscle, and posteriorly the gastrocnemius produce a tension and make the knee stable during your functional activity. So your gastrocnemius muscle, biomechanically, your gastrocnemius muscle is very less mobility muscle and more dynamic stabilizer. Sartorius muscle is a long ribbon-like muscle which arises anteriorly from the ilium. I already told you. So sartorius arises from the ilium. Sartorius muscle arises from the anterosuperior iliac spine and crosses the femur and inserted into the anteromedial surface of the tibial shaft and shares the pes anserioris area. The sartorius muscle will function as a flexor and medial rotator of the tibia. Despite its potential action of the knee joint, the activity of sartorius muscle is common in hip joint motion rather than the knee joint motion. Again, your sartorius work more on hip joint than the knee joint. It work on the knee joint, but compared to the hip and knee, it will more active. In a EMG activity, it will be more active at the hip joint when compared to the knee joint movement. So during gait, sartorius muscle is typically active only during the swing phase, not on the stance phase. Come to the gracilis. The gracilis muscle arises from the pubic symphysis, and it. So that is what gracilis, sartorius, and semimembranous, that is arises from the ischium, ilium, and your pubis. And common insertion to the pes anserioris tendons. The gracilis muscle primarily function at the hip joint flexor and hip joint adductor, as well as it have a capability to the knee flexion and produce mild medial rotation of the tibia. So in knee joint, it is also not much important than your hip joint. So it is very important hip joint adductor and flexor than your knee joint flexor. Other important muscle, popliteus muscle, it's relatively small and it's a single joint muscle. All the other muscle we saw previously is a double joint muscle, two joint muscle which cross hip and knee or knee and ankle, but the popliteus muscle is a single joint muscle which attaches posterior lateral femoral condyle and inferior medially attached to the posterior medial surface of the proximal tibia. The primary function of the popliteus muscle is medial rotator. You can see with the attachment itself, it pulls the tibia on the femur medially, and so it is a medial rotator of tibia on the femur. Also, in the opposite way, if it is in a closed kinematic chain exercise, if the femur moves on the tibia, it will do the lateral rotation. Because of the medial rotation of the tibia is required to unlock the knee. The role of unlocking of the knee is attributed by the popliteus muscle also. But if it is impaired or if it is paralyzed, unlocking mechanism will occur with the help of passive structure. So it is not much needed for unlocking mechanism, but it is an unlocking muscle. Move on to the important extensor. So compared to the flexor, your extensor is more and more active during all the activities of knee, weight bearing, open kinematic, closed kinematic, weight bearing activities, free movement of your knee joint, running, gating, whatever, running, your gait, your stair climbing, your extensor work. During your knee flexion, your flexor will not work, but your extensor work eccentrically to control the movement. So compared to the flexor, extensor are more active in EMG during all the activities of your knee joint, whether it is flexion, extension, whatever it may be. And also compared to the muscle bulk, extensor is somewhat cross-sectionally, it is more compared to the your flexors. So quadriceps muscle, the four extensor muscle, that is rectus femoris, vastus intermedialis, vastus lateralis, and vastus medius. Actually, vastus medius, forgot typing mistake. All together form quadriceps femoris, in which the only portion of the quadriceps that crosses the two joint muscle is rectus femoris. Other than that, all the muscles are arises from the femur itself. Vastus intermedialis, vastus lateralis, and vastus medialis originate from the femur, and it will merge with the rectus femoris in a common tendon called quadriceps tendon, and quadriceps tendon inserted the proximal aspect of the patella, and then it continues distally to the patella and past the patella, where it is known as patellar tendon. Again, the name differs, but it's the same continuity, or patellar ligament, and inserted to the tibial tuberosity, the proximal portion of the tibia, that is tibial tuberosity. So you can see in the picture the muscles. The vastus medialis and vastus lateralis also insert directly to the medial and lateral aspect of the patella, not by the tendon, also the direct muscular attachment to the patella. It's also merged with the tendon of your rectus femoris and form the quadriceps tendon. Also, it gives separate insertion to the patella medially and laterally. It is very, very important to stabilize the patella. That we're going to see about the patellofemoral joint. The vastus medialis and vastus lateralis, and also indirectly by the retinacular fibers of joint capsule. I already told you that it forms the medial and lateral extensor retinaculum, right? So it is also inserted to the patella by the connection of your retinaculum, extensor retinaculum of your knee joint. Together, all the four components of quadriceps muscle will do the function of extension of the knee, but the pull of vastus lateralis muscle alone will have 12 degree to 15 degree of lateral. Okay, so that tend to move the femur laterally or the tibia laterally, but your vastus intermedius muscle is a pure producing extension. Okay, because it is not crossing the hip joint, it's purely arises from the femur inserted to the tibia, and it's centrally oriented, provide a pure extension without any lateral or medial movement of your tibia. The upper fibers of vastus medialis were angled about, so you can see in the picture about the angulation. Your vastus medialis is somewhat angular than any other muscle. Vastus lateralis or intermedialis, it is somewhat more angled. So it divided into upper part and lower part separately. So upper fibers of vastus medialis angle 15 to 18 degree medially from the femoral angle, whereas your distal fibers angle as much as 50 to 55 degree medially. So it tend to move the tibia medially than the extension momentum. That is what literally it means. That is why it's mentioned here. Because of drastically different orientation of the upper and lower fiber of vastus medialis muscle, the upper fibers are commonly referred to as vastus medialis longus, because it's somewhat straighter. That is, it's have only angulated 15 to 18 degree, but the lower fibers is angulated larger. That is, the fiber itself look like somewhat oblique in nature, not in a straight manner. Vastus medialis oblique. Functionally, there's a lot of difference between vastus medialis longus and vastus medialis obliquus. Where we have medial instability, we have to concentrate, or we have to do exercise separately for vastus medialis obliquus. That is, obliquus training is very, very important in sports to train the medial instability of your joint and also the anterior. The resultant pull of your vastus lateralis muscle will pull your tibia 35 degree laterally, whereas the resultant force of your vastus medialis will pull 40 degree medially, your tibia. So when compared to both the muscle, your medial pull is more when compared to the lateral. Okay, so that is what about the quadriceps muscle, and what the role of patella present in between your quadriceps tendon and the patellar tendon. You have a sesamoid bone called the patella. What is the influence of patella? Why the patella is there in between the quadriceps muscle insertion? That is, it separates the quadriceps tendon and the patellar ligament separately. What is the reason? It is very, very important that the patella lengthens the momentum. So what to say about the momentum for the beginners? Momentum is the distance from the joint axis to the muscle action is called momentum. Whenever the momentum is somewhat larger, the perpendicular distance, not the exact distance, we can't be able to point the muscle joint axis. We have to draw a straight line horizontally, vertically from the center of the joint axis, and a vertical line from the muscle pull, and we have to unite the joint vertically, and it will give the distance. Like that distance is called momentum. Whenever the distance increases, your efficiency of the muscle to produce the torque will be more. Whenever the distance reduces, again the efficiency will producing torque in the sense angular movement, the torque will reduce. So you can't be able to do the movement. The momentum, like you compare the deltoid muscle of your upper limb, it will be easy to get it. So if suppose imagine your head of the humerus is not round, instead of that it will look like a flat lever. Then if suppose the deltoid muscle contracts, then your movement of your humerus will, your contraction of the deltoid will move the humerus parallelly to the not produce abduction force. That abduction force, production of abduction force is the rotatory torque movement. The extra protuberance of your humeral head, that rounded head, will make the distance from the joint axis to the muscle action widen. Okay, so it increases the distance between the axis and the muscle action. That's produce the more torque when compared to the angle of pull. So the same work will done by your patella. The patella will do the increase in momentum. The length of momentum will be increased while the patella is there. If you remove the patella, again there will be a lack of momentum, and again more compressive force will occur than the extensor rotatory force while we attempt to contract the quadriceps muscle. Quadriceps muscle without patella, we consider the contraction of the patella, contraction of quadriceps muscle without patella, it will more produce compressive force than the rotation force, that is extension. It will compress the tibia and fibula. It compresses the tibia condyle into the femoral condyle rather than it produce the extension. So it is very, very important to produce a momentum. The momentum and the word is very, very important in the biomechanics. So that produces a torque on all the joint to produce a rotation moment. So rotation in the sense flexion, extension, abduction, everything is a rotation around the fixed axis on the knee joint. So momentum is important word. The patella as the anatomical pulley, that is what? The rounded head anatomical pulley which increase the momentum, deflect the action line of the quadriceps femoris away from the joint center and increase the angle of pull and the ability of muscle to generate more extension torque compared to the horizontal torque, horizontal compressive force. The patella does not, however, function as a simple pulley, and the pulley tension equally. So it is not only act as a pulley, it is also a part which maintain the tension between the quadriceps tendon and the patellar tendon equally, so that your mechanism action will be smooth. If suppose your quadriceps tendon, the tension in the quadriceps tendon is more when compared to the tension created in the patellar ligament, that is the insertion point of the tibia, definitely it will have a functional problem that it will pull out from the tibia. It may be displaced or avulsion fracture will occur if there will be a difference of tension. So there will be equal tension maintained by the patella on the you may see the arrow mark here. So it is a patellar tendon, it's a quadriceps tendon, it's a patellar ligament. Okay, so the tension between these two will be maintained by the patella. So if there is a abnormal tension between the quadriceps muscle or patellar tendon, again create the functional problem. So this is what patella is doing during the flexion and extension. So the point from which the center axis to the line of action is called momentum. So during the early flexion, the patella is primarily responsible for increase the quadriceps angle of pull in full. Inside the intercondylar knots of the femur, so it can't be able to act as a pulley anymore if it is dislodged into the femoral condyle. So your femoral condyle itself is a rounded structure, right? So that will increase the momentum during the flexion to extension momentum. So in full flexion, your patella will take care of the momentum. In full extension, your patella will take care of the momentum. In full flexion, your contour of your femoral condyle will take care of about the increasing the momentum. By that, the smooth flexion and extension occurs by the extension movement occurs by the quadriceps without any interruption or without any producing compressive force on tibia and femur. During the knee extension from the full range of motion, that is what I just mentioned. So rounded femoral condyle will do that action. So approximately up to 45 to 60 degree of knee flexion, which both the momentum and the length tension relationship of the muscle is maximized. So in which position your patella is more activated or more production of torque will be more and more active in EMG is your 45 degree to 60 degree of flexion. So finally, it continues extension that the momentum will also again come into the diminished. So the more momentum is produced at the range of 45 degree to 60 degree. And the influence of your ACL, PCL also will increase the decrease of angle of pull of your quadriceps is evident. That is separate entity again. So ACL, PCL, function of ACL, PCL is not constrained what I thought already. It is more and more will take nearly 4 to 5 hours to complete the function of mechanical function of ACL, PCL. So again, ACL, PCL also come in act to enhance the movement of your quadriceps muscle. Just keep it in mind. Finally, stability function, knee stabilization. Okay, I'm not going to tell how the knee provides stability. What is the mechanism under the stabilization? I'm just going to mention about what are the components which provide the stability to the knee joint. So the support of knee may be classified by its function, the static and dynamic structure. That is static and dynamic structure. That is capsular, extracapsular, and the location anteromedial and anteroposterior. So static and dynamic. Static is passive structure, that is capsule and ligament. Already it's 8:15, I guess so. So we have to cover patellofemoral also. Let me make it fast. Static tension, static, the passive static. What are the structure? Static structure providing knee stability is passive structure, and dynamic structure is your muscles and associated aponeurosis, in which medial compartment stability. So that comprise anteromedial, medial, posteromedial. What are the structures which provide stability to the knee joint is medial patellar retinaculum, your medial collateral ligament, oblique popliteal ligament, and posterior cruciate ligament. Coming to the muscular structure, this dynamic structure, medial head of gastrocnemius, pes ancinus, and semimembranous muscles, which provide the medial compartment stability. Lateral compartment stability that comprise anterolateral, posterolateral, and the lateral part. So in the passive component, your lateral collateral ligament, that LCL, that is lateral collateral ligament, meniscofemoral ligament, arcuate ligament, and anterior cruciate ligament, lateral patellar retinaculum, the capsule extension, lateral patellar retinaculum. And the muscular structure is your iliotibial band, biceps femoris, and popliteus muscle. So these are all the structures which completely provide knee stability medially and laterally. Posteriorly, we already saw the posterior ligaments, and anteriorly, along with the anterior cruciate ligament, posterior cruciate ligament, the patella which tether into the tibia and femur, that we will see in separately at the patellofemoral joint. Okay, move on to the patellofemoral joint. Again, in patellofemoral joint, we are going to see about the introduction, articular surface of patella and the femur. I just run it out. And joint congruence, how it is congruent, how it fit into the femur, and patellofemoral joint motion. I just by the patella on the femur, and lateral and medial stability. You know the anterior stability of the patella by the quadriceps, but it will be easily, the patella will skip medial and laterally because except the main muscle which is not connected, muscular connect, which have no muscular connection medial and laterally. So some passive structure should be there to maintain the patella to the position of the femur condyle without shifting laterally medially. So the medial lateral shift stability is very, very important. Introduction, patella is the primary function of the anatomical pulley that I already saw in a quadriceps muscle. Interposing the patella between the quadriceps tendon and the femoral condyle also reduce the friction at the femoral contact with the hyaline cartilage, which is covered posterior surface of the patella rather than the quadriceps tendon. Articular surface. It is a flat triangular shaped patella, largest sesamoid bone in our body. The patella is innervated by a triangle with an apex directed inferiorly. The patella surface divided into a vertical ridge, which makes a medial facet. The complete patella is covered with the articular cartilage. Both the medial facet and lateral facet is somewhat slightly convex, so that it will dislodge into the convex surface of your shallow concavity of your femoral condyle. That's we are going to see about the articulation. Mostly the patella also have a second vertical ridge at the medial border that separate the medial facet from extremely medial edge called odd facet. Some person the odd facet may absent. So the posterior surface of the patella, you can see it in a picture. The posterior surface of the patella during the extension of the knee, it sits on the femoral sulcus at the anterior aspect of the femur, and the femoral sulcus have a groove that correspond to the ridge. It have a depression, that is a groove, which correspond to the ridges of your posterior patella, the medial and lateral patellar facets. The lateral patellar facet of the femoral sulcus is slightly more convex than the medial facet, or more highly developed lip, that is a thick lip formed by the femur that does the medial surface. The availability of the patella to perform its function without restriction of the knee movement, it's depend upon the mobility of the patella. If there is a restriction of the mobility of the patella, its whole knee joint movement will affect. So because of incongruence of the patellofemoral joint, however, the patella is depend upon the static and dynamic structures for its stability. So static structure is your ligamentous and passive structure is your muscle. So without that, it can't be able to do the proper action. Patellofemoral joint congruence, again I already told you it is incongruent. Fully extended knee, the patella lies on the femoral sulcus. Because the patella has not yet entered into the femoral groove, the joint gravity in this position is very minimal. That is why they can able to move the patella medially, laterally, or upward and downward during the full extension, but we can't able to do that in a flexion because it's which is completely lax at the fully extended position. So the joint congruity is very minimal. It suggests that there is a great potential of patellar instability during the extension movement. The stability of the patella affected by the vertical position of the patella on the femoral sulcus, because the superior aspect of the femoral sulcus is less developed than the inferior aspect of the sulcus. That is why whenever it goes into the inferior sulcus, it is safe. But if it is dislodged at the superior sulcus, it is somewhat shallow concavity, not much concavity to accept the patella inside it, so it is somewhat wavy, that is unstable. The vertical position of the patella in turn relates to the length of the patella tendon. So the situation of the vertical position or orientation of the patella is so that the patella is also situated vertical without any movement, without any deviation of your angle of inferior angle, straightly vertically because the orientation of the patellar tendon. So ordinarily the ratio of the length of the patellar tendon and the patellar ligament, that is patellar tendon superior and the patellar ligament, is 1:1. Okay, so that is very important. The length of the patella. Okay, here I have a picture to measure. I forgot the inside. Okay, so the tendon, length of the tendon of the patella, above the patella, the length of the tendon of the quadriceps, and below the patella, the length of the patellar ligament, we call it as, from the patella to the insertion of the tibia, that is tibia ligament or patellar ligament. So both the length are equal. That is why it dislodges the patella into the proper position of the femur. If there is a variation of that length, that ratio of patella is approximately 1:1, and that referred to as insalvability index. It is very important to measure the patella alba and patella baja. Okay, so if there is any high position of the patella, if the patella, if the quadriceps muscle pull is more, will stretch over the patellar ligament or the at the insertion point of the tibia, then the patella somewhat move high. That is called as patella alta, we used to say. in a pathomechanics. Other than that, the contact of patella at the various stages. Okay, so the patella will not come into contact during the complete extension. Once the flexion starts, then the patella will come into contact with the femoral condyle. So during the flexion, your femur the contact between the patella and the femur occurs along with the inferior margin of the both that started at the 10 to 20 degree of knee flexion. It come to the first inferior angle of patella will come into contact with the and then your middle and then your upper part of the patella will come into the contact. That is how it contact. In 90 degree of flexion, all the portion of patella will be experience some sort of contact except the odd facet I already told you. So except the odd factor, all the patella come into the contact with the femoral sulcus. Again, if the flexion progresses again beyond the degree, somewhat the contact will migrate inferiorly. So this is how the 30 degree, 60 degree, 90 degree, the patella will dislodge into the femoral condyle and getting the contact. The picture says, so during the 0 degree, during 30 degree of patellar contact, during 30 degree, you can see the inferior part of the patella is come into act. During 60 degree, somewhat above. During 90 degree, your medial facet and lateral facet have equal contact. And again, 180 degree, the contact will come less. So that is what here the picture indicated, the contact of picture. Contact of patella on the femur. Patellofemoral joint motion, you have flexion extension. It accompanies along with the flexion extension of the knee joint. So in the first picture, this is the flexion of patella. The flexion patella come into the femoral condyle and the femoral condyle is extension, come into the femoral condyle is your flexion. And your medial lateral tilt. Okay, so medial lateral tilt that here. So without moving the patella horizontally, only the medial border of patella touches the femoral condyle, then it is a medial tilt. Lip of your the lateral facet, the lateral border of the patella will touch the lateral lip of the femoral sulcus, will form the lateral tilt. There is a medial and lateral tilt. It's a transverse movement of patella medially laterally is called patellar shift, medial shift and lateral shift. In this picture, I mentioned about the patellar lateral shift. So patellar shifting laterally in a horizontal path without any rotation, and medial rotation, lateral rotation. The inferior angle of patella, that in a triangle, the apex of triangle moves medially, it is medial rotation. If it is moves laterally, it is lateral rotation of tibia. Passively, we can do all these movements in full extension, but during the flexion, we can't able to do the movement of your tilt, shift, or your medial. And finally, we move to the medial lateral joint stability. Before that, I just want to convey about the joint reaction force is very, very important to maintain the integrity of your patella on the femur. That is the pull of quadriceps tendon and the pull of patellar tendon below, the patellar ligament below towards the tibia. So towards the tibia, it's somewhat angle oriented towards the femur shaft, so that our patella pull inwards into the femoral condyle and it makes the integrity between the femur and the patella. If suppose any of the pull exceeds or any weakness occurs in the quadriceps tendon, your patella will move medially, laterally, or superiorly, inferiorly. So, and the joint reaction, whenever the patella, the quadriceps tendon and the patellar ligament compress the patella on the femur equally produce a force that will oppose the compression of the patella, that is joint reaction force. That is also very, very important to maintain the integrity of the patella on the femur. I didn't mention about the joint reaction force of patella here. Just want to convey it. And the medial lateral stability. So medial lateral stability, we have two components. Imagine before we go into the medial lateral stability in a old Bollywood movies, yeah, the villain of a movie used to tie our hero into the from right arm, right leg, left leg into some distance with a rope, which is not seen nowadays films. So like this, your patella is tied medially, laterally, supromedially, supralaterally, infralaterally, superiorly, and inferiorly, so that it will integrated with the tibia and femur. So that is how it provides medial and lateral stability. I already told you a lot of ligaments. I missed out in the ligaments, that all ligaments come into act at the patella. Whatever the ligaments which connects the tibia to the patella or femoral to the patella provide the medial, whether it is medially or laterally, provide the medial stability and lateral stability of the patella. So during full extension, patella will not come into the contact with the femur. Once the flexion begins, the medial and lateral stability of the patella is purely dependent upon the active and passive tension around the patella. So the patellofemoral is under control of two restraining mechanisms that cross right angle to each other. That is your transverse group of stabilizer and longitudinal group of stabilizer. So transverse group of stabilizer. What are the transverse group? Transverse group in the sense side to side, and longitudinal group up and below. Okay, upward and up and below structures. So transverse stability, okay, medial and lateral stability provided by your medial lateral patellar retinaculum joins along with the vastus medialis muscle and vastus lateral actively, and your medial lateral patellofemoral and your iliopatellar band, which is a band coming from the iliotibial tract. Longitudinal stability, what I already told you, like the tiding heroes at the climax, the old Bollywood movies. Likewise, so it is tied superior laterally, inferior laterally, and superior medially and inferior laterally, so that it have a complete contact with the and so the longitudinal stabilizer, that is, you know, that the patellar tendon inferiorly and quadriceps tendon superiorly and the patellotibial ligaments. Okay, so the transverse and the longitudinal structure influence the medial and lateral positioning of the patella. So that is called as patella tracking. Medial lateral positioning, that is what I already told you, so I'm going to skip it. And what are the force acting medial laterally to maintain the integrity, in which very important about the orientation of the quadriceps on the relation to the tibia and quadriceps. During active knee extension, quadriceps or quadriceps passively stretched, the tibia will pulled by the quadriceps. So the force of patella determined by the resultant pull of quadriceps and the pull of patellar tendon. So it is decided, the situation or the location of the patella is decided by the pull of quadriceps and pull of quadriceps superiorly and pull of patellar tendon inferiorly. So these force of quadriceps and force of patellar ligament will not coincide, so it tends to pull the patella somewhat laterally. So the increasing lateral force and the lateral compression of the patella towards the lateral lip of the femoral sulcus during the extension is obviously seen, and the lateral aspect of the intercondylar during the knee flexion is obviously evident because of the pull of your quadriceps, pull of your patella laterally than medially. So that will be compensated by the vastus lateralis that pulls the patella 12 to 15 degree laterally. Vastus medialis pulls the patella 15 to 18 degree medially, so that it maintains the integrity. And your vastus medialis obliquus will pulls on the whole about 50 to 55 degree medially the patella. So the vastus medialis is very important to maintain the integrity of the patella on the femoral condyle. If the VM was weak, then the patella move laterally. Okay, so that is very important. That is why whatever the thing happen, we have to train the vastus medialis obliquus during the sports injury. If any medial component gets weak, it will affect the patellofemoral orientation. So the net force or pull of your patella will form a critical angle called quadriceps angle, which is differ from your tibiofemoral angle, which I already told you, that is 185 to 190 degree. It's quadriceps angle. So the important biomechanical measurement, whether the quadriceps is oriented with the femur or the patella is oriented with the femur, the angle formed between the line connecting from the ASIS to the midpoint of the patella and the line connecting from the tibial tuberosity to the midpoint of tibia. So this is tibial tuberosity, a straight line from the tibial tuberosity and a straight line which intersect the center point of the patella to the ASIS. Okay, in which these two lines form a small angle about 10 to 15 degree in full full extension normally. That is called Q angle. Okay. If the angle is more than 20 degree, then it is abnormal. We can guess that there is lot of excessive lateral force will occur at the patella that will lead to the pathological changes. Okay, so that's about your patellofemoral joint. So make the summary. That's all. The class is over. For the summary, we saw about the two broad classification of your knee complex, tibiofemoral and patellofemoral. In tibiofemoral, we saw about the structure and function. In structure, we saw about the articular surface, articular congruence, and the weight-bearing structures, and the ligaments, capsule, the capsular extension, in which we saw about the ligaments, the important ligaments, collateral ligament, medial collateral, lateral collateral, and anterior cruciate and posterior cruciate ligament, other posterior ligament, which is important to provide stability for the knee joint. And then we move on to the muscle, the flexor and extensor, the flexors by the hamstring and other muscles, and extensor by the quadriceps muscle and its mechanism, and the stability function, medial lateral stability provided by the ligaments and the muscles. And then we came to patellofemoral joint introduction and the structure of patellofemoral articulation, and patellofemoral movement, patellofemoral joint congruence, and the force of medial lateral stability, the force that provides medial lateral stability, in which we saw about Q angle. So that is what we saw in today's class, and thank you for listening. I know it takes long time, and this is also not enough to complete the knee complex. I just tried my level best. I don't know whether it is understandable or not. Thank you.
Thank you. You justified the topic, giving a full package of knee.
Thank you, sir.
Thank you so much, sir. Rupesh?
Yes, sir.
Is there any questions?
No, sir. Any questions?
Dear participants, you can write your questions in chat box, or you can raise your hand and talk to our resource person.
Sir, I think the chat box is disabled, so nobody can message.
No, only for you it is disabled. Actually, Rupesh is having the proper connection there.
Okay, sir.
Deepthi Mahedu. Rupesh, unmute Deepthi.
Yes, sir. You can unmute yourself and speak if you want. You can write in chat box, or you can speak out, participants.
No, sir. It was by mistake. I'm sorry.
No problem. There is a question, Rupesh.
Yes, sir. From Mr. Jayadarshini. Sir, what happens if we don't have patella bone?
I already told you that the patella is the main thing which increases the momentum. So, if the patella is absent, the momentum will reduce, so that the torque produced by the quadriceps muscle will reduce. So, more than producing the rotation, that is extension, the patellar tendon used to do compress the tibia on the femoral condyle rather than it will do the extension. That will be happen if there is absence of patella. It's somehow compensated by the femoral condyle, but the patella is much needed during a complete extension. Even though if you have some patients have patelectomy due to the complicated patellar fracture, comminuted fracture.
Sir, your audio is struck, sir.
Sir, there?
Sir?
We'll wait. Check in the participants.
Strengthen the VMO separately. Yes, you can Google it.
Yeah, he is there.
Hello?
Your voice was struck.
Sir, your audio was temporarily unavailable. If you can repeat, sir.
Yeah, okay. So again, I repeat the answer for the question. What happens if patella is not there? The momentum between the quadriceps tendon and the femur will reduce. So it will produce the compression force between the femur and tibia rather than the rotational force. So literally, it will not extend the tibia. It will rather compress the tibia on the femur if the patella is absent. But it will not always happen because the femoral condyle contour is more, so that will somewhat compensate the mechanism or increase the momentum. But patella is one which enhance the momentum, that will be ease the movement of your tibia on femur during the extension. So patella is very, very important.
Fine,
Second question, can we strengthen the VMO separately? Yes, you can Google it. A lot of suggestion you can see the VMO training. So we can do the strengthening separately, yes. But it's again a lot of big topic to explain how to do the VMO training. You just can find it. Answer is yes, we can do VMO training separately.
Any more questions, dear participants?
Pooja Paryani was raising her hand.
No, sir. One more question is there from Ms. Nainika. What causes extension lag, sir?
Yeah, mainly the weakness of quadriceps and the failure of locking mechanism is the main problem which cause extensor lag. So the passive structure, if there is any problem with the passive structure which produce a locking mechanism, or if the quadriceps is weak, and also it is believed that the vastus medialis obliquus, I already told you, the medial oriented force, which also unique in producing the final degree of extension, that is the locking, medial rotation. Actually, it is not needed, but if the passive structure is absent, then the VMO will come into act. So that is also an important factor producing extensor lag. Extensor lag reason, extensor lag. I don't think the what is extensor lag? Extension lag. Extension lag is that is the final 5 degree of extension we can't able to do if you can't able to tight your quadriceps muscle at the final end of the degree. And also for that we have to do VMO training. That will be give good results for enhancing the final range of extension. But I don't think extension lag. I don't think the term exists, extension lag. It is a lag only. Some others may say it is a lag. That's it. There is no difference between extensor lag and extensor lag.
Sir, one more question from our YouTube viewer. Pain and crack sound produced during stair climb, but no pain occur other than movement. Any reason for this?
Yes, it is mainly due to the patellofemoral arthritis. If it is old age people, if it is occurs for an young age, it's maybe a chondromalacia patella. It's inflammation of your articular cartilage behind the patella on the femoral. The classical sign, if you can ask the patient, they may have a classical pain and the crepitus while they are stepping down the stair rather than climbing up. So you can differentiate whether it is if it is in a young age, it is just an inflammation caused inflammation, that we call it as chondromalacia patella. If it is in old age, that is after 40 years of age, it may be osteoarthritis, patellofemoral arthritis.
Fine, sir. Next one is from Mr.
What is the recent studies we can strengthen? But in recent studies, we can't strengthen the VMO separately. I don't know. Still, it is believed that VMO can be strengthened. Okay, so mechanically, VMO can't strengthen separately. Whenever we attempt to strengthen the VMO, the quadriceps muscle is also gets strengthened along with the vastus medialis obliquus. But the concentration or putting the strengthening or weights to the VMO, particularly if to the particular range, that is from 45 degree to 60 degree of knee flexion or knee extension, if you put an isometric contraction or somewhat laterally rotated knee joint, the weight with laterally rotated knee joint, if you do the flexion extension, that will give more weight on the vastus medialis obliquus than other component of quadriceps. But it is not possible to give separate strengthening, but we can give importance to the vastus medialis obliquus during the strength training. It is, you can. patellofemoral syndrome management. It's a separate entity about patellofemoral syndrome management. Patellofemoral syndrome, it's a broad classification. Patellofemoral syndrome is caused due to the inflammation. Patellofemoral syndrome caused due to the alternation of the biomechanical passive ligamentous structures. So it's depend upon the causes of patellofemoral syndrome. The management will differs. That again a different entity. Can you explain clearly what is momentum? Okay, so it's very important biomechanics, the momentum. Simply just keep it in your mind. Momentum is the thing which increase the torque production by the muscle. Torque is the angular movement, you know that. Okay, so the rotational movement. Each and every muscle have to produce the rotational momentum. Then only it will pull the lever. That is bone is the lever. It will pull the lever to the desirable action. That is flexion, extension, abduction, adduction. Everything is the rotation movement. So from the joint, it is a joint. Joint have an axis in which the axis your ligament, your joint, your bone is moving. Flexion, extension, or abduction, adduction, whatever. Whatever the action is commonly called as the rotation around the fixed axis of joint. So joint is a part of fixed axis in which the bone, distal bone or proximal bone in a close kinematic chain, are usually the distal bone will move or rotate. Okay, so that you have to learn about the lever system. So axis and the lever, how it is movement. If suppose some other pulling force that will pull the two levers or two bone, proximal distal bone towards each other, it will produce more compression force. If suppose a pulley or any other structure, rounded structure which present in between the bone and the muscle force, then rather than it will pull, it will compress, it will pull the lever to the desirable action, flexion, extension, that is rotation. So that is called momentum. The momentum exclusively is a measurement ranges from the center point of the joint, that is joint axis, to the line of muscle action, the perpendicular line of muscle action. Whenever the momentum increases, there will be increased torque production of the muscle. Without much muscle activity, the movement will occur with ease. That is what the function of momentum is. Anything?
Raj, if you want to speak, you can unmute yourself. You have raised your hand.
Good evening, sir.
Good evening.
Hello. That was a wonderful session, sir. I just want to know, there is any normal variation in the Q angle in males and female? If so, what does it cause the variation?
Yes. Female have somewhat more Q angle because of wider simply. So
Wider pelvis.
10 to 15 is normal for female. Wider pelvis, because of wider pelvis, the Q angle is somewhat more for female than male.
So how much it is the normal angle for them?
10 to 15, it's exceed up to 20 degree for the female. It's normal.
So does it vary during the pregnancy time?
Angle of valgus, yeah. Once the pelvis get into wider, again it's a big topic. Once all the mechanism of weight bearing structure will differ, so it will put more weight on your lateral part. Again, it will produce a varus tension. The varus force on the knee joint will be more. That is why they have a different type of walking. More than the widening of pelvis, your quadriceps angle also increases along with the pelvic getting widened during the pregnancy. Yes, definitely it will affect the pregnancy. Actually, biomechanically, the pregnancy is a form of condition which produce problem for the mechanism, that each and every joint, the pregnancy will be considered as a pathomechanical thing. Usually it is a normal physiology, but mechanically it creates a lot of problem to the normal mechanics of the joint. So the pregnancy is considered as a pathomechanic part. Yes, definitely it will varies, and it is not good for joint. It will not good for the weight distribution on the patella to the femur and create a problem during the pregnancy. So as a biomechanics, pregnancy is not a normal thing for me, for the joint mechanism.
Next question, Rupesh.
Yes, sir. Next one is from Ms. Rutwa. What should be the treatment for congenital absence of patella?
It's like any other congenital disease that we have to adapt your mechanism without the patella. Again, the momentum will be reduced. So compared to the normal persons with patella, they have a wide range of difference during the extension. They have to use their quadriceps more. Usually, for the treatment, surgical correction is needed to impart any other structures, soft tissue structures should be imparted between the femoral condyle and the quadriceps tendon to increase the momentum, or else they produce more compressive force than the rotational force. Again, your femoral condyle will come into act. So complete extension, it is very difficult for them to do the initial degree of flexion, and from the extension, it will be easy for them to do the extension up to 30 degree, and from the 30 degree to 0 degree extension, they have a lag producing the quadriceps tendon tension because of absence of patella. It will be corrected surgically, not biomechanically. Nothing can replace the absence of patella biomechanically.
Yes,
Okay, thank you, sir.
Next one is from Ms. Prachi Dubey. Any special exercises for patellofemoral osteoarthritis?
No, again, osteoarthritis is erosion of articular cartilage, so you should not give much stress to the joint. Even if it's an acute phase, if it's in a chronic phase, you go for a normal quadriceps strengthening exercise that will give strength to the patellofemoral joint also, and also for the tibiofemoral joint. The common exercise, your quadriceps strengthening of quadriceps is more enough during squats.
Next question, Rupesh.
From Mr. Velavan, during squats, is there any changes in the length of quadriceps muscle?
No, length of the quadriceps muscle, physiologically, the length of the quadriceps muscle will not vary. I don't get the question actually. What is you mean about the length of quadriceps muscle or length of quadriceps tendon? Actually, during the squatting mechanism, the muscle will get pulled during the flexion. The quadriceps muscle work eccentrically and lengthen its length actually. It will lengthen to some extent to provide stability to the knee joint during the squat position. Squatting literally a knee flexion, but the muscle activity of your quadriceps will be more on your squatting mechanism. During the squatting or raising up from the squatting, your quadriceps muscle will work more, and there is an increase in the length during to getting down to the squat, and decrease the length to getting up during the squat. Getting up position. Yeah, it varies with the length according to the eccentrically it will elongate or concentrically it will contract. Other than that, the quadriceps muscle length physiologically it won't happen.
Fine, sir. Next one is from Ms. Karishma. Is VMO helpful to the OA patients?
For the OA patient, again, we have to assess the OA patient mechanically. So that is what I insist to my students, that in orthopedic condition, more than we assess clinically about your motor assessment, whatever the sensory assessment, we have to add biomechanical assessment also. So osteoarthritis, whether it is in a medial osteoarthritis, whether it is in a tibiofemoral arthritis or patellofemoral arthritis. If it is in medial femoral arthritis, mostly the medial joint space is reduced usually. So whether it is a medial space reduced or lateral space reduced, whether the weakness of medial structure or lateral structure, if there is a weakness of your medial structure, the orientation of patella will more producing compression over the lateral part, so that you have to train the VMO. It's depend upon kind of osteoarthritis or kind of pressure or kind of force which is distributed on the knee joint, it will be useful. If suppose it's a medial compression force, so the medial part of the thing is already tight and the lateral part will get into lax. If you train the VMO, that will not give a proper result. So it's depend upon the force acted on the knee joint during the osteoarthritis. We have to change our exercise protocol. So definitely have to do the biomechanical assessment, the force assessment, before prescribing the exercise, from my point. Anything else?
I think we can conclude. I think no more. Any questions, Rupesh?
No, sir. No.
Okay. We will conclude. Thank you, ANAND BABU sir. You have really had a lot of patience. We went for 2 hours actually. They might have watched the premiere movie by this time.
It's about
really,
9 now.
Really very much informative.
Yes.
As I told you earlier, it is a full package about me. And recently we had a surface palpation for the knee joint also. So if both they were attended, it will be a very informative for participants. So I thank you very much. I thank all the participants and YouTube viewers for your patience and support. I thank my ExRxIndia team members, Dr. Rupesh and Professor Duna, for the continuous support. And I thank co-host Vairo also for his support today. And I thank everyone. Good night. Bye-bye.
Bye, sir. Good night, sir.
Thank you, sir. Thank you, Vairo.
Thank you, Anand sir.
Rupesh.
Thank you, Chandramohan sir.
Thank you, Duna.
Thank you, Anand sir.